Okay, good afternoon everyone. Thank you for joining us. This is the 63rd in the series of Global Health History seminars brought to you today courtesy of the Wellcome Trust and the University of York. It's my great pleasure to welcome Dr. Venkat Raman, author of a new book, Public-Private Partnerships in Healthcare in India, which has fascinating chapters on why famines still happen in a globalized world, etc. I recommend this to you. There will be 2 copies shortly in the library. Dr. Raman comes to us yesterday from Delhi, where he is an associate professor at the Faculty of Management Sciences at the University of Delhi. He has a master's degree from the Tata Institute of Social Sciences in Mumbai and a PhD from the University in Delhi. And he has worked with the World Bank, USAID, DFID, GTZ, KFW, the Population Council, the Population Foundation of India, and Options. As a consultant, and before that he comes from an NGO background working in urban slums and tribal areas in India, and he's going to tell us about how the private sector interacts with the public sector in healthcare delivery in India. He will then be seconded by Dr. Hongwen Zhao, who works in the department in HSS called Health Delivery and Governance, or Health Systems, Governance and Delivery Services, something like that. Dr. Zhao has an MD from China, an MPH from Hopkins, and a PhD from La Trobe University in Melbourne. He's also worked in the World Bank, although I don't think these 2 gentlemen have met previously, and for the Ministry of Health in China. And he's worked on worked on a research agenda around the commercialization of healthcare. After the 2 speakers, there will be time for questions. This seminar is broadcast over the web, so if you wish to ask questions, please identify yourself. Please note that people speak in a personal capacity and not on behalf of the organization. Let's get started. Thank you very much. Dr. Raman.
Thank you, Laura. And first of all, let me at the outset thank World Health Organization, Wellcome Trust, and the University of York for inviting me and giving me an opportunity to share some of the research that we have been conducting since almost a decade now. I should also acknowledge the contribution from my absentee research colleague, Professor Bjorkman, with whom we have been doing this research for several years. In 2003, we got some grant from Dutch government to look at some of the possible innovations in health sector. One of the innovations that we were trying to track was, at that point of time, there were a lot of debate about private sector involvement, with the debate on tertiary care being given subsidies and whether they were meeting up to the public health objectives with which the subsidies were given. And we went around the country, looked around what are the possible involvement of private sector in the delivery of services, not necessarily looking at the tertiary services, but also the spectrum of, a wide spectrum of services. I dare say that most of PPP or public-private partnership models in India have evolved since 2002. And there are some of them who were there in late 90s, but most of them began in 2002. So we were in fact almost at the first year or second year of its project inception, and we have been tracking since then till last month. I'm sure this particular point need not be, or rather would be an understatement if I were to repeat this. There has been a virtual collapse, or maybe I should say a breakdown of the public health sector. It's not necessary that I talk about only in Indian context, but I guess this particular parameter or maybe judgment could be applicable to several countries, both in Asia and Africa. Apart from the financial resources, there is a huge resource gap in the human resources. A ballpark point or maybe an estimate would be about 45% of India's public health system is understaffed, or rather there is a vacancy. Now, it's unlikely that in the near future the public sector is going to be attractive for competent medical professionals or health staff to really come in. Unless there is a huge civil service reform, it's unlikely that you will find these vacancies getting filled up. So in the absence of hospitals or health facilities which are functional, so the poor who otherwise would have relied upon the free services from the public sector have no option but forced to go to the private sector. It's not by their choice, but by no other option. Simultaneously, you would see that when the debate about reforms, restructuring of health system in the country, there was a sudden mushroomed growth of the private sector. One estimate says that in India, during the freedom, at least in 1950, early 50s, the private sector was primarily dominated by missionary hospitals or trust hospitals, and they constituted about 8% of India's health facilities. The 2000 data or 2005 data speaks a very high volume of health facilities in the private sector. I should say that almost 80% of doctors, 64% of health beds, almost about 80% of outpatients, 57% of inpatients are accounted in the private sector. Now, this is something that is again not typical of India. I'm sure this is perhaps true in several other developing countries too. We can have a lot of debate about what were the reasons why there was a rapid expansion of the private sector. We can debate that at a later juncture. But you cannot ignore the overwhelming or omnipresence of the private sector in Indian context. So, what are the implications of this, or what is the consequence of this? The consequence is that the poor are forced to go to the private sector. We have this scenario which I mentioned to you. This is, at one point of time, these data were thrown up by World Bank documents, and we, as generally every health activist would like to suspect World Bank reports, we also suspected that this must be one of the ways of, kind of advocating greater private sector investment in the health sector. But repeated documents from the government of India re-emphasizes the growth of the private sector, an unaccounted or unregulated growth of private sector. As a result, today, when the private sector is accounting for the largest proportion of patient volume, irrespective of whether they are in rural areas or in urban areas, you have poor to pay almost 80% of their health expenditure from out of pocket. Again, we say this from the overall estimate that India spends about 5.5% of GDP, out of which only 1% is from government and the rest is from out of pocket. So that's an estimated volume of out of pocket expenses. The consequences of that is poor, almost, again we go back to one of the government documents which says that in India people fall below poverty line. 2% of India's admitted patients, or rather hospitalized people, fall below poverty line every year. So the option available to the government is there a way that you can actually weed the poor from paying out of pocket, or would you be able to pre-purchase the services from the private sector and allow the poor to access the services free of cost? That's the broad context in which this entire debate about PPP is examined here. And this particular presentation that I am making here is not based on one singular case study. We have been tracking several case studies, and therefore much of my comments would be on a broader policy implication level rather than operational details. So given that the public sector hasn't been able to meet the health goals or health goods provision of health services, and the private sector is not a saint-all kind of approach, so we have this option that is there a way that both of them can optimize their own mutual strengths and reduce the weaknesses. The strength of private sector is resources, its own access, or rather its omnipresence, or its availability of services 24/7. The public sector, despite its own mandate, isn't able to really meet up those kind of challenges. So it's this particular context in which my debate about public-private partnership is. These are the general hypothesized, I use the word hypothesized because these are all empirically to be validated. So I'm using the word that these are hypothesized benefits. As of now, we are trying to do some of these, whether it has improved the excess, whether it has reduced the out-of-pocket expenses. That's the line of inquiry in the last 2 years I'm trying to do. So global literature says that working with the private sector would perhaps benefit the public sector along these lines. So you will, I don't want to repeat what's there, so you would know that there is a particular a huge benefit for both the public sector and the private sector. Now, what exactly is the essence on which we are talking about the public-private partnership? And there is a lot of rhetorics, a lot of ideological divide about the public-private partnership. Some people would like to coin it as a backdoor privatization. Some people would like to call it as simple, universal way of coverage of health services to all population. But in our own context, in the form of a theoretical interpretation, if I were to go back to the Bloom's model of who finances and who delivers the services, you see that particular yellow cell, which is basically the cell that we are talking about. I would like to reiterate again that delivery of services in the public hospital isn't likely to vanish. The private hospitals are also not likely to vanish. Given these two sets of realities, there is an alternative that you can also think about exploring. That private sector delivers the services on behalf of the government, and the government finances them, rather pre-purchases it. So the purchase modality is what we would be looking at, the public-private partnership here. What possibly, I mentioned to you that there are plenty of interpretations about what constitutes public-private partnership. Any kind of interaction, whether you buy stationary items, whether you contract your security guards, whether you maintain your equipments in the hospital, all of them are broadly brushed aside and said that these are all PPP. They are not truly. PPP should have certain minimal criteria of equality, autonomy, mutual decision making, benefit to the beneficiary, the patient. So there is a fine theoretical line that we have in our own book demonstrated that the public-private partnership needs to be seen from a Puritanist point of view rather than looking at every engagement with the private sector as a public-private partnership. These are some of the attributes of public-private partnership we have debated in or we have defined in our own book, and therefore you would again see that there is a huge equality between both the parties, our partners, that requires to be the pillar or the strong foundation on which the partnership will survive and shine. Now, before I go into the next level of my debate, I would like to just illustrate some of the major models that in Indian context have been popular. And these PPP models are in operation, have been in operation for the last perhaps 7, 8 years. Some of them have been successful, some of them have not been. Generally, most PPP models have been contracting. And recent emergence of both supply side and demand side financing in the form of vouchers or coupons or transport vouchers, institutional delivery vouchers, etc. Joint ventures in Indian context have been a failure. The joint ventures when we talk about is when the government wants to transact, barter, a kind of a land and barter with the private sector to provide 20% or 30% or 40% of beds reserved for the poor. And this has been under a legal scrutiny for a very long time, and we haven't really found a good model which works very well in the joint ventures. But the rest of the models seem to be having a mixed kind of a picture. And I'm just going to give you some of the models which are in operation, which are successful ones. Primary health centers given to an NGO to run. This is currently about 60 primary health centers in the country. Across the breadth of the country is being experimented or piloted, and they are working successfully. We have several issues about it. I'm not getting into the details of how these contracts, what are the problems associated with these. They are not without troubles. Each one of these contracts have evolved over the years, and initial years have been really troublesome. This is the second model. In Indian context, we have the primary health center, then the community health center, and then the district hospital. This is a community health center, again falls within the overall purview of primary care. This is a tertiary care hospital. The lessons from this are hugely relevant for Indian context, because there are many state governments have built the hospitals, tertiary care hospitals, super specialty hospitals, but they are not able to staff them. In a city like Delhi, there are two big hospitals with an investment of about 9,000 million rupees. And both these hospitals for the last 2 years have been lying vacant because the government was not able to hire specialists to be placed in these hospitals. So this model, which was originally brought about in 2002, has so mixed lessons that many governments are failing, or rather fearful of going in the PPP mode. The problem is, don't blame the PPP, but the way that it has been contracted. That's the idea to be learned from this. This is about contracting of radio diagnostic services. And this model has been upscaled across the country, one of the most successful models, and had been upscaled across the country. This is one of the most popular models in Indian as a lesson. This is on a demand-side financing. It's a Chiranjeevi scheme, it is called. It's meant for women to go to visit any pregnant woman to visit to any of the private hospitals or nursing homes, deliver her baby without paying anything, and even as of now, this particular project has been expanded to cover infants up to 28 days. So the entire project starts from antenatal care till 1 year of the baby's survival. So this project had over the years have matured and have become much better. Similar kind of model in another context has not been doing very well. The earlier model which you saw was a bulk model, and this is an individual reimbursement model. So demand-side financing, both of them apply very similar kind of tariff structure, but they don't work in different contexts. So again, a lesson, PPP does not necessarily be, replicated just because it was successful in one context would be successful elsewhere too. This is a community-based health insurance scheme, wherein the cooperative farmers from one of the states, southern states in India, pay a very little amount as a micro-insurance, if I were to say, as a paraphrase, and they get about $3,000 worth of cardiac surgeries or minor surgeries worth of services available. This is a particular kind of a model which is very useful for highly difficult terrain. The terrain that you see in the circle of in the Indian map is a terrain which is 80% of this particular province is hilly terrain. So static facilities don't work in these places because people by 5 kilometers or 6 kilometers would be equivalent to something like about 20 kilometers in a normal terrain. So the mobile health vans have been doing a human service there. We have tracked this about even looking at how much people save in terms of their out-of-pocket expenses when they reach these places instead of going to the static facilities. This is a telemedicine project which is again in one of the southern states of India, and there is a corporate house which is now coming, and it's doing, the kind of a service is unimaginable, the amount of investment that you make and the amount of benefits that you can get from this. I'll focus on what are the possible lessons. One of the possible lessons, I look at it from the point of view of who are the key stakeholders, and my comment would be restricting to some of these stakeholders, not necessarily all of them. Well, the public health system. Let me at the outset say this. In India or in many, perhaps in many other developing countries, PPPs have evolved out of basically goodwill, out of good faith of some bureaucrats and some people in the private sector. And there hasn't been any systematic approach to the notion of PPP within the government. You will hardly find, there are 29 provinces in India, you will hardly find one, except one state or one province, none of the other provinces have a PPP cell or a PPP unit, or forget about even PPP, private sector cell. Private sector has mushroomed in most of the states, but there isn't a single official unit which looks after these particulars. The 70% of health sector is in this particular sector, private sector. So there isn't any system, institutional system, that have really advocated or stood by the PPP. There is an institutional capacity problem. People do not know how to design a contract. People have no idea how to monitor it, because most of the contracts have been kind of a moderated version of what happens in the road sector, what happens in the airport sector, what happens in some other construction sector. So it's a kind of expectation that similar tender process will also be useful in health service delivery, which is unlikely to be very successful, because there in construction sector you have a definite product, whereas here, unless you develop those service level contracts, service level agreement details, you will not be in a position to track. And the most difficult part of public institution has been, most of the public institutions have been based on this tendering process, which means that L1, I hope you understand the word L1, lowest bidder. So the concept of public-private partnership does not rely on lowest bidding person. You've got to have something different. Somebody who demonstrates the quality of services is as important as the cost efficiency. And bureaucrats are trained to look at the lowest bidder, and the lowest bidder invariably compromises in terms of the quality. And the lowest bidder always wants to compromise because he wants to enter into the government contract. Once he is in a government contract, his contract in other places becomes easy. And this is one of the major concerns that we have been having as to, should we have a two-bid process of technical, financial, should we have a single bid process? So there is a debate that we have been involved in this. It's frozen? Okay. In terms of the private sector, in Indian context, the private sector is hugely diverse. You have not only the system of medicine, which is practiced, but also the level at which people provide services. There are individuals, there are corporate hospitals. There are people who are in rural areas, there are people in urban areas. People who practice allopathy and people who practice Ayurveda. So private sector by nature is not homogeneous. And the number of health establishments in India is not more than 5%. And government is never trained to engage individual practitioners. Government is always trained to engage with establishments. Because even if you look at the tendering clause, you should be having a minimum turnover of this, you should have a minimum of beds of this, and therefore individuals go out of the picture. So that's another complication vis-a-vis with the private sector when you want to engage them. The second is, there isn't any uniform guidelines or norms for accreditation or standards. Leave alone the clinical standards, leave alone the rational practices of drug administration, etc. Those are all highly sophisticated words in Indian context. Just even if you have 5 beds, even if you have a polyclinic, physical norms, many of the private health establishments operate from car garages, residential premises, the basement of somebody's house. Right? There's one of our document in National Commission on Macroeconomics and Health which says, in India you can open a beer bar only with a license, but you can open a nursing home without license. Okay, that's a kind of a statement which describes the overall power of the private sector in terms of their own ability to resist the accreditation norms, physical standards, and their ability to withstand any kind of pressure for violating any kind of malpractices. And the ones that I marked it in red are the contract-related problems. Most PPPs have been failing because of payment delays. There have been instances where payments have been not paid for 13 months for an NGO which is supposed to have got about 30 million rupees meant to be paid to an NGO. Can you imagine an NGO running with 30 million rupees? They should be doing a corporate business rather than into an NGO. There aren't any grievance redressal. If somebody do not pay, somebody is, some political pressure is there. There isn't any place where I can go and say that as a private person that here is an harassment that I am getting. Can you please address this? In terms of bureaucracy, the top bureaucrats are wanting to be seen as pro-reform. PPP is one of the pro-reform slogans. All top bureaucrats wants to be seen as somebody who is pro-reform. The moment they initiate a project or a scheme, they get transferred. There isn't a continuity. The next person doesn't share the same sentiment. The next person wants to have his own legacy rather than the legacy of the past. The lower bureaucracy suspects all PPPs as privatization and losing their job. And since they have not been part of this entire debate, so they think that someone from the state headquarters have dictated to them what to do, what not to do. And they don't get involved. They say, you go to hell, I don't care. You want to use this facility, use it. Don't bring any problem to me. Okay. The civil society or political class is quite ambivalent. At least political class is very ambivalent. They would speak according to the group that they address. If they go to a medical council or medical association, they will say, oh, we would like to work with you as equal partners. Let's achieve all health goals together. But if they go to a village community or panchayat, then they will say, no, private sector is exploiting you. We will not allow private sector to come in. Civil society was always squeamish about private sector. The word private sector kind of a red rag against them. So it's a kind of a problem that they continue to have, because justifiably so. Because if you look at the last but the penultimate point, government had never been able to regulate private sector. How can they be really contracting and managing the private sector might? All right? So that they have a point to also mention. In India, we have Clinical Establishment Act in 2010, but there is it's a kind of legislation in the hands of somebody who has absolutely no teeth. Clinical Establishment Act neither has any penal clauses, nor does it have penal authority as an institution. So in a way, you have only given a set of guidelines, but there isn't anything to enforce on it. I have this to my friends in the development sector. They all want to prove that they have value for money to their own constituents back home. And they don't really stay back to really demonstrate that beyond handholding, beyond the pilot projects, there is a need for you to continue this. They want to leave a footprint. They pilot a number of schemes, but afterwards they find it, oh, we have done so wonderful work, and then go back to their home country and make a good report and say that we, from this particular agency, have been able to demonstrate this. These are some of the enablers of good PPPs in Indian context. There is a prior consultation, that's very important. Pilot testing before it gets expanded. There is a timely payment. There is an acceptable level of supervision and monitoring, if not a very robust system, but a little bit of acceptable level. Every PPP that have been successful have been able to define the overall objectives of PPP. Unfortunately, some of the PPPs have not really made that kind of a contract. Would you, if I could show you sometime later, there is a contract which just runs half a page. There is a contract which runs almost about 20 pages. The 20-page one gives you performance indicators, whereas the half-a-page contract just says that you are supposed to provide services 24/7. All the primary care services that are supposed to be part of this establishment need to be provided. What are the constraints? Perhaps I'm taking a little time more than what I should be. Sorry, it's another 2 minutes. There is a lack of clarity about the definition of PPP. This is both at the theoretical level as well as at the practical level. There is a problem of lack of understanding. Why PPP? There is a problem of who are the beneficiaries, especially when it comes to the high-value services. You saw one of the examples of a tertiary care facility being given to a private provider to run. 40% of beds are supposed to be meant for the people below poverty line. They carry a car. And you would see that a person who drives, we in Indian context, Hero Honda is, Honda Motor, Honda car is a luxury car. I was in the field, I see a person who drives a Honda car, comes up with a BPL card and says that my son is to be admitted. Now, who has the courage to really say that, no, you are not a BPL person, that is below poverty line person? There is a problem in high-value services. The monitoring of who actually gets the benefit isn't known. There is a lot of political interference in the service delivery. Somebody calls up and says that you admit this person under BPL category, we will give you the cards or documents later. There is a payment delay, there is an institutional problem or capacity for monitoring. There is also a problem of personalities between the private sector person and the bureaucrat. If they don't get along, payments get delayed forever. There are kickbacks, allegations of kickbacks, there are payments to be made before you get the released payment, etc. In a final way, I would like to really put this across. Regulation and institutional systems are the two foundational stones or pillars for PPP. If you don't have these two, PPPs don't work well. If your institutional system is weak, you do not know where you are headed on that side, on the PPP. If you don't have a regulation, you don't know whom to contract. Then you go back to the tendering process rather than on the basis of certain standards. I would like to summarize my presentation on this, that there is an inevitability of working with the private sector. You cannot just disown private sector in any context. Private sector is there to stay. People have a choice to make. People's ability to, or the public sector's own inability to re-attract the patients which they lost to the private sector will require to be addressed. I am repeating this, PPP is not privatization. PPP, the role of the word public, as long as the word public remains, public has full control over the way that it wants to purchase services from the private sector. So in no way I would like to really say that PPP is a backdoor privatization. And the last part, which I would like to really repeat this, remember, PPP is not a solution to all. Public sector will continue to provide services, private sector will continue to provide services. Till the time public sector is not able to attract or not able to give confidence to the poor that they will get drugs, they will get doctors, they will get services, you would have to think about something different from your existing myopic perspective. Thank you so much. We have this book, you can have a look at it. I can also send it. If you want to look at all these case studies that we mentioned in a detail, you can look at the last one, you can note down that. Thank you so much.
Well, just now, Dr. Venkat gave us a very excellent presentation about the India case on PPP. What I was talking about today, unregulated commercialization and also PPP. I gave a case study about hospital reform in Brazil and China to try to illustrate what's the difference between unregulated commercialization and what's the PPP, and why unregulated commercialization doesn't work in China, and why PPP works in Brazilian's public hospital system reform. I will try to speak about 5 topics. First, what is the unregulated commercialization and why? And then I'll talk about reactions, debate, and actors around these areas. And then I will give a case about the hospital reform, and then a little bit about theory of evolution theories in this area, and then concluding with the contract or trust, which is the 2 governing mechanisms for PPP and also for another type of partnership. Defining commercialization in healthcare. McIntosh in 2005 defined the commercialized healthcare as provision of services through market to those able to pay, investment in and production of those services, and of inputs, the inputs for the service, or for cash income and for profit. So basically it's for cash payment and profits. That's the commercialized healthcare. WHO 2008 report defined unregulated commercial care as unregulated fee-for-service sale of healthcare, regardless whether or not it is supplied by the public, private, or NGO sectors. So basically, it's a fee-for-service sale of services, regardless of any sectors. That's the definition of unregulated healthcare. Why we do this? Because we think it affects large populations, unregulated commercialization. And there's some negative consequences about unregulated commercialization. So for people, it may lead to health empowerment. For health system, it may cause trust, to the system, and might have influence on the microeconomic situations. Because if you have underground economies, while that's not, the government cannot taxation on that. Or simply, because people try to savings, for their, catastrophic illnesses, the money has not been used efficiently. That can affect our microeconomies. For social institutions, it might institutionalize inequity and also delegitimizes the state. So that's as an impact for society as a whole. Now, why it comes that I think there's a paradigm shift, basically about talking about the development in the 80s. Basically, people think about there's a coming from in the 60s to 80s, there's a public sector, investment as a way for promoting development. But since 80s, there's a new public management school which calling for a marketization process that may be helpful for development. And there's an ideological justification that less state is better. Then this idea has been generalized into the health sector. It has implications at the meso level and also at the micro level. Basically, in the 80s, there's a coping strategies in many low-income countries. There's also talking about harnessing partnership or engagement with private sectors. Those terms are spread in the 80s and 90s. But there's problems with institutions and incentives with regarding this kind of trend of the last 2 decades. Effect on service delivery. For many low-income countries, there's a fragmentation, simply they're adapting to the donor fundings. As mentioned by Venkat, those people tried left a footprint there. So there's also individual coping strategies, commercialization. There's no quality follow for the services. This has also been mentioned by Venkat just now. And also there's dangerous chaos, what we call safari surgery. It simply means you open the abdomen, do nothing there, then stitched opening again, then that's over. So, but that has to be paid, So that's dangerous care. For many transitional economies, the commercialization has also existed, but this has three negative impacts in what we call inverse care, misdirected care, and also fragmenting care. Those are documented in 2008 report of WHO. Now, the effect on institutions and governance. For many low growth economies, there's institutional inflation simply follow donor money. And also the strategic discussions between donor and recipients replaced by individual donor-client relations. Quite bad politics there. For the transitional and emerging economies, there's also a passive state, with less financial leverage to influence the whole health systems. And there's also illuminations, for competing for efficiency, yet without functioning market. And this, we observe this in many transitional economies in East European countries. And also for many, providers, individuals or hospitals, the institutional survival strategies dominate. So they try to survive, Then that's introduced commercialization. Now the reactions to this phenomenon, to this trend, opinions are quite mixed from different circles, and evidence is also mixed. So, but there's also institutional actors, towards this phenomenon. So I will explain this in details. The major debate maybe, we can document is the IFC, the International Finance Corporation report 2007, and followed by 2011, and then Oxfam on the other side, IFC is saying that, the private sector is good, that can work, but Oxfam say, well, that's called blind optimism. So there's debate on that. Currently still debating, but the conclusion that is searching for evidence, searching for high-performing organizations that can solve problems. So that's the idea. Now the institutional actors within this house, a lot of people doing around this, PPP and PPT, public-private partnership and TV programs, reproductive health, I saw that was there, was doing this. And there are also people doing different things, contracting, service deliveries, and it's also, good governance for medicine program. That's WHO. Now, other agencies, outside WHO and groups working on that sector, there are lots of agencies working on this. These are the publications, so you can search for this, different understandings, different practices everywhere. So that's the situation, the overview about the situations. Now I try to give you a case, it's a single case of public hospital reform in China and in Brazil about unregulated commercialization and also public partnership in terms of hospital reform. Here, this is the the starting point. In Brazil, in São Paulo state, and also for China, I generally regard it as a tertiary case, it's hospital-based hospital sectors. The starting point that for Brazil is public hospitals basically and direct administrations, same as China, what I call the public integrated models, basically for service, finance, and administration are integrated together, and that's a kind of a command and control mode of regulation. The pre-reform issues for Brazil and for China are similar, basically dealing with incentives and accountabilities of the public sector, all the same. But Brazil has some private hospitals, but they don't like to contract with private hospitals simply for that. First, they have agreement, but that agreement is weak, very weak. It's difficult to monitor and supervise. Second, there are some political connections between the public and private sectors, which can be, say, nepotism or whatever. And so the indicators for contracting is simply just service volumes. There's not enough power to leverage on the private sectors. That's the idea. Now, the reform. In Brazil, they use the PPP model. So a non-profit operator as a manager of the public hospitals. This introduced this idea. What is non-profit operator that is called OSS that has been created by the law in 1998. That's the public interest organizations. So they will compete for contract. So, then they have contract with the state health department and contract with specifications. So that's Brazil. That's the reform. For China, it is the fiscal decentralization. Another way of reform simply means decentralization downside, which is local governance, and the decentralization outside, which is go to the track the market. That's the idea. Then China has created so-called self-governed hospitals, simply reduce the budget to hospitals. So you find your own, you try to find your own revenues through whatever services which you can provide, and then you earn monies. That's the idea, the self-governed hospitals. And the purchaser has been set later in 1997. We try to leverage influence, but because when I say purchase means basically the demand side, social insurance program. But because of the coverage is very low, so they cannot influence enough about the behavior of these self-governed hospitals. So that's the starting point of unregulated commercialization in China. Now, the accountability mechanisms of the two-way of reform. In Brazil, they have very nice, contracts, have specifications out there. But with China, there's less specification between hospitals and the health department. Only focus on financial audit and appointment of president of hospitals. That's the idea. But Brazil has really contract. And second is about the payment mechanism. Brazil has very detailed way of payment schedule. China, basically based on the claims for hospitals. And largely it's fee-for-service payment for bulk of private patients because there's no coverage at that time. So that's the way of introducing the unregulated commercialization. So you can see the difference between the two models. The incentives of the providers. In Brazil, there's a limited market exposure, There's no competition for selling service in the market. While in China, there's volume competitions. So you have difficult to check the qualities. So there must be quality and volume trade-offs there. So that's the situation. And if we can charge the patient in Brazil, but China, we can charge fees to the patient. The residual claim right, that's the surplus claimed by the hospital director, whatever. They can pay for their own benefits. Say selling service for their own benefits, that's the idea. Brazilians say no, but China has bonus pay for staff and also for hospital directors. So that's the way. Governance arrangement. Here in Brazil, it has standardized the cost accounting systems in all PPP hospitals. China simply found a focus on financial audit to self-governed hospitals. It's a weak type of supervision, while Brazil is more strong. It's standardized across hospitals. It's benchmarked, basically. And then there's the contract enforcement unit in Brazil and also in China. But China has limited tools to do that. In Brazil, they have contract and also have money to influence that. Let me summarize about key ingredients of the two-way of reform. First, basically, there's autonomy for both type of hospitals, Brazil and China. Second, flexibility of health, human resource management. But for China's case, they have less been used. They don't fire doctors, basically, as the most hardest way. Strategic projects, yes, contract. China financial leverage is less effective. The idea is coverage at that time, not now. Contract enforcement, which is okay. They have quality indicators and now have information frameworks to do this. For China, largely fee-for-service payment. That's the definition from what I mentioned at the beginning. Fee-for-service sales of, so regardless public or private sector, that's unregulated commercialization. So that's blurred, the situation between public and private sector. Information transparency, benchmarking for budget negotiation between health department and the operators who manage the hospitals. That's Brazilian case. For China, there's no information framework across hospitals. So each hospital behaves individually. So it's a regulated fair market. Let me conclude about the situation of China, from 85 to 2009, 2 decades of this unregulated commercialization practice. First, there's market segmentation. It benefits the rich segment of the population. Second, there's a high out-of-pocket payment, reduced access of the poor. That's the situation. And the second, there's a blurred distinction between the public and the private sector. So I said public sector is decentralized down, but it's also, earn bonuses, so the market mechanism. So public sector do that. And there's a lack of quality benchmark and price signals that truly reflect cost. The price has been controlled, for services, but price has been given to prices for medical equipment and for drugs has been given to market. So that's distorted price structures in China. And in conclusion, the commercialized healthcare needs to use effective regulatory regime. The central idea is that if you want to have more a marketized reform, then you have to institute the regulatory regime first. Otherwise, it'll be very, very bad. Now, let me give you some idea about the evolution of series dealing with this, this kind of ideas, about how to deal with this, say, marketization or PPP or contracting, whatever. Kenneth Arrow, the founding person of health economics and also the Nobel Prize winner in 1963, basically say the health market, that's a failure simply because information asymmetry. Just key point. Then how to do that? Then in 72, he said that you have to restore, in order to restore the market to be functional, you have to establish professional ethical codes so that, the reputation and the trust can be established between providers and the patients. So that's the idea. Then the state, in order to do that, then you have to regulate, to promote self-regulation or either co-regulation for safety, cost, and quality. And also states have to redistribute for access for poor, or whatever, that cannot be benefited through the market. These are the current practice and also the past practice about the role of state, so broadly speaking. Then in the 90s, there's a huge, because of the huge transition from planning to market in many East European countries that also affected health sectors. And then there's new institutional economic schools and try to apply this in the health sectors. They use 3 theories: the theory of property rights, the theory of agents principal relations, and the theory of transaction costs. Try to privatize the providers so that they can provide services to the population. That's in many East European countries have done this. And then in 2001, Jacobson saying we need a new framework, try to balance state and market. That's his thinking after the practice of the past 2 decades of the paradigm shift. Then the idea is partnership, which described by just now by Venkat. So it's called mutual cooperation and responsibility for achieving specific goals. That's the whole idea. Then the real situation is about how to develop this new frameworks. In mature economies, I mean OECD countries, they have highly, developed market systems and also regulatory regimes, so that it's quite fun, for their social program, social insurance program, whatever. So they can do that basically. But in many low and middle income countries, low and middle, am I saying, it's very difficult, to have such kind of a social insurance to cover the large population care, simply because there are not enough tax-based funding or other way funding for general population. So the reality is that there's unorganized market, regardless of informal or whatever. And also it's difficult for states to have law, to enforce law, because it's so organized. So how to deal with this? People now think about try to establish certain sort of new social institutions and actors that will try to form certain type of new social agreement or contract, formal or informal. So gradually people can follow certain rules to provide services. If there's no contract, if contract cannot be enforced correctly or effectively, as mentioned by Dr. Venkat. So this is the idea proposed by Gerard Bloom in 2008. Basically, he's thinking about we need to have a iterative process to generate rule-based activities in which reputation-based trust and market-based contract may operate more effectively. That's his idea, to try to respect those contracts. I think this idea is more or less, in the correct way for many low and middle-income countries. This is my work from China in 2005. Basically, before the reform, the situation is quite simple for China. There's only two boxes, two white boxes, hospital and health department. The relation is quite simple. It's within big, bureaucracy systems. So in that sense, people get care through hospitals. Fairly simple. But if you try to move towards market-oriented system, then you have to create a complex systems and institutions and actors. Now you have four things. You have hospitals, you have health department, you have market-driven consumer, I mean the patient without any insurance coverage, and you have the patient covered by the insurance. So those are four things. And try to link those four boxes, you have five rule boxes which you have to define. That's the difficult part. You have different markets there. You have to define, and you define rules, and you have to get people adapted to the rules in their behavior. And people might respond to different incentives. Then you have to think about to construct a certain type of a social agreement for people to behave properly so that overall the market can be functional. This is the difficult part for China. So that's why we need certain type of, say, social agreement, or in Jewish term, social contracts. In that sense, the whole market can be functional. So that's the idea. Okay. In the conclusion for this, global summit, I'm go through this kind of practice and theories. Let me give you some ideas of the evolution. First, medicine and science and art. That's we have long been regarded as that is. It is. The problem is that the professional autonomy has been challenged because of organized market. The industrialization, the medical technology. Really, those things, changed the autonomy of medicine as a profession. Then we resort to economic approach. But Ronald Dworkin, the author of Lost Empire, he mentioned that distributional equality with respect to exercise of individual liberty through market mechanism for both equality and welfare is impossible. It's impossible to do that. And that market as an ethical base are in fact false. That's it. Then we think about the way to regulate and how to regulate. That's so-called the legal approach. But the problem that governing requires not only technical competency, but also moral competency. You have to think about the way that the social norms that people can share and can agree and can follow. Otherwise, you have many rules, regulations, laws in the textbook, never put into practice. That's the problem of the legal approach. So then you come to the sociological approach, how to build communities so that people can follow rules and then to reduce what we call the social transaction cost. So that's the whole idea. So in that sense, I'm still thinking back to the social contract idea of try to spread reputation-based trust mechanism that's rooted in the community as alternative contract using PPP, so that at least all the community members a happy life. So that's my idea. Thank you.
So thank you very much to our speakers. The discussion will be moderated by Sanjoy Bhattacharya, who's a long-standing instigator of this seminar series and host from the Wellcome Trust and University of York. He'll take your questions, and if we have questions from the webinar, Julia, if you could signal those. Thanks.
Well, thank you, everyone. It's wonderful to see such a fulsome participation in what has been a wonderful set of talks. Could I again reiterate our request that you identify yourself and you ask questions, because we have, I think, a lot of colleagues today on the webinar listening in. So I'm sure they'd love to know who you are and what department you work for if you're from the WHO. I'll start off with a couple of questions. Professor Venkat Raman, it's a fascinating presentation, but I wonder, and you have to forgive my question, I'm a historian by training, historically, what role has the WHO headquarters or the regional office played in helping regulate PPP or encourage PPP in India? And also, I wonder, in relation to China and Brazil, was there WHO regional office involvement in encouragement of PPP structures, and did the cultures of working in these regional office influence the way PPP unfolded in the Western Pacific Regional Office and the Pan American Health Organization? So if I could leave it to you.
I always believe that maybe I am wrong, but I always thought that WHO does not have favorable or at best an ambivalent approach to private sector engagement, except in drug discovery and not in service delivery, because I presumed, or I continue to presume, that WHO's insistence that it is the public sector's domain to really do the service delivery. But having said that, I think WHO regional office and CRO played a very critical role in regulation. I think some key actors in the CRO office had played a key role in bringing out the Clinical Establishment Act of 2010. That much I can only comment about. Okay.
Well, for the involvement of PAHO and also WebPro in this work, for this work I have been done prior my involvement in the WHO work. So I would say not really involvement WebPro and PAHO. For China, this reform, I think that's involvement of World Bank. They have seminars and workshops regarding how to reform the hospital sectors. I mean, the leading person is Alex Creek of the World Bank. Who I mentioned his mode of reform. WHO involvement, really don't think so.
Thank you to both the speakers for excellent presentations. My name is Bhupinder, and I work in Alliance for Health Policy, which is under HSS cluster. And it's encouraging because before coming here, I was associated with health reforms in the state of Uttarakhand, and it's very encouraging to see those mobile vans that you were showing, because I was closely involved with both replicating the Chiranjeevi model in Uttarakhand as well as these mobile vans. But I think one question would be like, mobile vans like there were two vans which were running in the Ramnagar sector, Ramnagar area, with the collaboration of Department of Science and Technology, the TIFAC. But later we upscaled and we also went in PPP with HLL, Hindustan Latex Lever. So it'll be interesting to see if the management changes, what are the kind of lessons learned. And I mean, I'd be more keen to learn about that, the vans which are run by TIFAC and the vans which are run by other NGOs, how do they compare and contrast? And I would also like to attract your attention to some of the NGOs, PPP that we also started with Uttarakhand, where instead of giving the management of PHC or CSC to NGO, you give the whole area, the remote rural areas, we'll give it under the Health Reform Sector in Uttarakhand, and that also played a very important role in meeting the access demands, at least in the basic preventive and primary services. So that's one area where I didn't see in your slide, if you haven't covered, that's one area which you would like to cover. My another question is when you are comparing the tertiary hospitals and saying that you give it to private sectors, what do the private sector do in getting, if the public sector is not able to attract manpower, what does the private sector do in attracting the manpower, and what are those things? And I think most of just to share with the audience, most of these reforms or the PPP ideas, they come generally from the donors, but also comes from the individual, as Dr. Venkat Raman said, from the individual kind of enthusiasm that few of the bureaucrats or officers they show, and then they want to do something for the state. So many of those ideas they came. In fact, the Chiranjeevi model also came through this way when I had a meeting with Dr. Amarjit Singh when he came to Uttarakhand. So it was kind of dialogue with him. He said that's how the ideas came up, and that's how those reforms got implemented. Thank you.
Okay, hello. Since I think if you look at the mobile health van, that slide, you will understand that as I mentioned to you, this particular terrain, the provincial terrain is 80% almost hilly region, and it's not easy to access this place. Somewhere in the early 2002, 2003, it was with the involvement of Department of Science and Technology, and there was a government of Uttarakhand, there was another private institution which demonstrated in the form of what they call it as a technology demonstrator, that they could reach out to the farthest places in this remote location and could provide entire complementary services of a primary health center, including ultrasound and X-ray and things like that. Currently, the entire province had replicated this model into all 13 districts. That's not the problem. The problem is there is no more involvement of TIFAC or DST, so it's completely by the government of Uttarakhand. But that's not a problem. Problem is much more than that. The technology demonstrator who made it successful model out of this is running the model of same van in one of the districts, and the contract is out for 13 districts. 11 districts have been given to one politically affiliate body, NGO, with double the contract amount that the original inventor of this particular mobile van. So you have this undercurrents of PPP. If it takes the political tone, it can have a huge differences in terms of contracts. To put it in a different way, I shouldn't be saying these figures. The TIFAC or the BISR, that is Birla Institute of Scientific Research, which originally was the inventor of this particular van, currently gets about 3.5 million to run this van as an annual basis. On the other hand, the politically affiliated NGO gets 8 million rupees. It's more than double the amount. So that's one of the problems that we have been having in terms of how do you really bring this out. When we asked the contract for them, they slashed out all the financial details, and we got only the contract details, which were uniform for both of them. The second about the primary health centers being given as on the territory basis, I think that's not really taken off in the province that you are mentioning. Currently, there are some states which are doing that, but they are doing only at the primary health center level, which is about, when I say primary health center, it's about 30,000 population. So the entire primary health center along with the sub-health centers have been given to these NGOs to manage, including the immunization, reproductive child health services, tuberculosis control, HIV screening, etc. So the entire complement of services have been given to these NGOs.
No, in fact, I was thinking that, the lessons learned from this could also come up in your presentation, like, what are the things to do, not to do, and what are the things to be. And also the tertiary, like, how the private sector could bring the manpower, which the public sector is not able to, that's not answered.
I think private sector, the incentives are greater, number one, because there is I think one need to understand that the doctors are not afraid of getting posted in rural areas, but they are afraid of being forgotten there. That's one of the problem about public health sector, that there is you post this particular hospital I mentioned about in one of the remote locations of South India. The private sector themselves were not able to really bring the manpower. Out of 25 specialists, last time when we visited, only about 13 of them were there. But the rest they were able to get them on part-time basis. But how the Nepal is addressing the same problem is that they are asking, now the medical colleges are knocking at the government's door and say that we will send our specialists to learn from these places, and we will send our postgraduate doctors to stay there for 6 months. And we will make it mandatory that if they don't spend their 6 months there, we will not give them degree. So it's a different approaches in different contexts.
Yes, I'd like to put out a sort of provocative thesis out here. Maybe that it could also be time to recognize that the PPP has been an abject failure in many situations. If you think of big diseases such as HIV/AIDS, TB, malaria, vaccination, or also widespread situations such as diabetes and diarrhea. And because the partners who are asked to implement this, the one side, the government, has no money, private sector, if you allow, has no interest in really curing patients, and these two partners are asked to tango in an impossible situation and will fail or will take very, very long time. So isn't it perhaps indicated to look at other solutions? I'll put out there the term of a benevolent dictatorship. Maybe in some situations, these two partners, they don't function together. And there's the expectation of the global community that they function, but they cannot because of the different interests. So sometimes there may be, for example, in the area of vaccination, immunization, there may be a call to go for a governmental approach of dedicated people who have a dedicated mission and are able to implement it with the necessary funds and don't need to quarrel about PPP contracts, whose obligations are what, and in that way to actually eradicate a disease effectively. So that is my question.
Please identify yourself.
Oh, sorry. My name is John Lober. I work for the Stop TB partnership here in WHO.
It's a tough question to really answer. I think to begin answering your question, I think the fundamental question is, who is more desperate to become partners, or who is more desperate to get into PPP? I would for sure say that it is the government, because government takes the obligation to provide the services to all the people. It's not the private sector who is desperate in this PPP situation. That's number one. Number two, wherever drug interests becomes predominant, you will see that the government's responsibility is dictated by the bigger private sector interest. So the reason why perhaps one would think about disease control programs, you have certain other interests rather than the public health goal becoming more predominant. I think in India we have been very successful in HIV in bringing on the HIV control program the role of NGOs and the private sector. I think that's where one of my earlier work with the Population Foundation of India, where we have been able to demonstrate district level networks can be established for the HIV people, PLHs, who could then be able to leverage their own influence, collective influence with both the private sector people as well as government to get their own, the rewards or maybe their whatever their demands have been. I'm not sure about the disease control program as a broad base. You can put a paint canvas of that as a failure. I think PPM strategy for tuberculosis has been has demonstrated that you can do at least surveillance, if not treatment or complete treatment. With MDR, you don't have any other option but to get the private sector onto board. Otherwise, you are going to have plenty of people with MDR.
If I can pick up that last point, I think is not working. The last point specifically on the MDR, what is often said, lack of suppliers, lack of products. What if the government were to decide to produce the medicines themselves at the cost that they think is appropriate and distribute them? Then there is no longer this pull and push with the producers to lower prices, to raise the production capacity, etc. That problem would be eliminated at a cost, of course.
Asked. In case of a Brazilian-China hospital reform, the PPP is more served as an instrument or contract way to try to improve the inefficiency of the public sector in the case of Brazil, because Brazilian, state of São Paulo state, I realized the inefficiency of public sector. So simply want to exchange the management, through contract. In the contract, they specify, the terms, the quality indicators, and payment schedules so that they can follow. Because previously, public hospitals, they also have agreement, but it's weak, so they cannot follow. So it's more like to impose a hard constraint for hospital to perform more effectively. Okay.
Madam, and then we'll take a question from the webinar.
I'm Julia Lee. I'm actually an intern in the maternal, newborn, child, and adolescent health department. And following up with John's question, in a way, it's twofold. It's one around the idea of cost effectiveness. At least in my home country, the very few attempts that there have been in the private sector, I'd have to say, were actually private sector initiated and have pretty much generally been more expensive than if the public sector had taken on the initiative on their own. And so I wonder around issues about cost, and not that cost effectiveness is the only or best measure of how care is provided. And secondly to that is the ethics of access. You had mentioned stuff around 2% of hospital beds taken up by the poor in India, which I don't think is proportional to the amount of the poor people in India, or reservation of certain proportion of beds for those below the poverty line. Knowing that there's a correlation between socioeconomic class and need for access to health care, and knowing as well that the private sector is very often not so interested in equity of access, how do you correlate those two things together around ethics of access while trying to still be cost effective?
Corrected about the 2% figure. I think 2% figure when I mentioned was that there is an estimate that 2% of hospitalized Indians fall below poverty line every year because of cost of hospitalization. Most of the contracts are not contracts, but most of the joint ventures are land for patient volume, etc., admission, etc. These are all dictated along the lines of 10%, 20%, etc. That is, if the hospital is a 100-bedded hospital, if the government gave them a subsidized land, they are supposed to give 10% of that or 20% of beds meant to be for the poor. Yes, private sector would not comply to those kind of obligations if they were not really monitored. the notion of monitoring is that would you be able to really put your own inspectors there at the door and say that who will be actually admitted in these 20 beds? It's not a very easy task, but both, I mean, how do you really make this work? Because the patients are not going to the public hospitals to get admitted. For some reason, they are not in a position to really go any other place except coming to the private sector. It's not that the private sector, they would like to really voluntarily go, because private sector is a kind of a daunting one for them. People are poor are much more, kind of feel a sense of intimidation when they walk into a private sector hospital. The question is, do we have a trust-based relationship between the government and the private sector in working together on this? There have been instances in Bombay, or in a city like Bombay, where some of the corporate hospitals, I wouldn't like to name them, but they have really come forward to help the poor patients. Not necessarily that there is a contract, not necessarily that they took the land, but some other perhaps a philanthropic way. That's a demonstration story that you may have to really talk about to others. But when we talk about some of these practices that corporate hospitals don't follow, these are in some rare situations and they tend to be played off. There are several people who are doing good job that never gets highlighted. As a result, private sector invariably is painted in bad picture. But at some point of time, you will have to really break these jinx. I do not know when it's going to happen, whether it will happen at all, but one just hopes for the best.
Yeah, I'm Satyajit Sarkar. I'm with the Department of Nutrition. One area which I'm totally unfamiliar with, but I suspect it has an influence, is now the big emerging private health insurance in India. How is that influencing the public-private partnership scheme of things? Some idea you can give us?
There is a Ministry of Labour program which is about 3-4 years back it got launched, called RSBY. It's in the form of an acronym. It's called Rashtriya Swasthya Bima Yojana. Okay, it's kind of a national health insurance program. But remember, this particular program was not launched by the Department of Health. It was launched by the Department of Labour. And the labor, which meant that these are migrant labor. And they can hold a card and they can walk into any of the hospitals. Now there is an insurance company, these are all based on the private TPAs, and the private health insurance companies are the ones which hold this particular grant or this particular subsidy, or the premium that gets collected from both the central government as well as by the state government and by the public. And the patients are asked to walk into any hospital, whether it's public or private. And invariably, we have been seeing that the patients have preferred to walk into a private hospital. And the private insurance companies did not expect this. So even in the one that the community-based health insurance model that I talked about, in the first 2 years of its inception, they have taken a beating in terms of they didn't expect that the patient volume will spike. But it had stabilized because there is an interest among the patients that they would like to get involved and then get their problems addressed, and then slowly they don't have to really renew their membership. But some of the provisions of this particular premium has made it sure that they continue even though they receive the treatment in the first year, which I think they are turning around now. We are talking about this in the context of universal health coverage rather than in the private health insurance for middle class or upper income people.
My name is Manjul Joshipra. I work here at the VIP department in WHO. Clearly this is an important question because more and more governments are thinking of purchasing the care rather than providing the care, and that happens as we've seen in the examples from Brazil and China to the most successful examples of NHS in UK. So this is going to come. Going back to your question about contracting, the difficulty with that, I'm sure there would be several models which will give some guidance on how best to contract it out. And the most recent one came to my mind when I looked at this very recent proposal from Hong Kong. Interestingly, they have factorized the cost and the quality as to 30 and 70. So 30% is for the cost and 70% of the quality, and they've come out with some wonderful parameters on looking at the quality, including the services, accreditation, education, research, and whatever else. And the cumulative cumulative bidder will get the contract. I mean, I'm sure the governments in emerging economies can look at certain models to sort of work through their system.
Most of these contracts are designed by transaction advisors. These are global consulting companies. I'm sure they prepare wonderful reports. We can have a debate about that later too. But the problem comes, most of the government servants are not in a position to make out what these contract clauses are. I mean, if the government had the capacity to really design this, understand the nuances of those contracts, and release the payment according to those fulfilled obligations of the private sector, we wouldn't have the problems. But it is the lack of participatory or lack of involvement of the bureaucracy from the top to bottom, from the inception of the contract or from the TOR stage till the implementation and release of payment. And that is the major point of crisis. Because in the absence of a dedicated unit of officers trained into the nuances of understanding the contract, it makes it difficult for them to just follow those, okay, clearance, payment cleared, on what basis? That's when they start wondering what is the parameter on which they release the payment.
Yeah, okay. Are there... I mean, of course, I mean, in the UK, the other aspect of PPP, which... okay. So we have a question from, I think, the University of York. I recognize the name. And Karthik Sharma asks, what do you have to comment on the cost efficiency of the PPM dots in TB care in the 14 PPM pilot studies, and is their scaling up justified? There's a minefield of a question which I'll leave to...
All I can say, Karthik, is that there is a revised RNTCP program that's going to be in stage 2. And I think this particular issue would be taken very seriously in terms of reviewing it. I think next Monday there is a meeting to really look at some of these models and whether they are effective enough. I think one of the problems of PPM has been that individual contracts of dispersed nature, which has really made it much more difficult to justify the cost of involving individual practitioners. So there is a new proposal that has just been brought to their notice to the second RNTCP group, that is to appoint nodal private sector agencies at the district level so that they themselves in turn engage or have internal contracts with the private providers, individual providers. We will see how this evolves. Perhaps 6 months from now we will have a clearer answer.